We can start, please.
Hello, good morning, Mr. Khalid.
Good morning, doctor.
I'm Dr. Bukhari and I have been asked to talk to you and do your examination. Is it fine with you?
Yes, doctor, thank you.
So, may I know what brings you to the hospital today?
Actually, doctor, I felt that everything became black in front of my right eye. Actually, I thought first that time that I imagined, but when it recorded, I feel something serious.
I'm sorry to know this. So, has it happened before?
Actually, doctor, as I remember, I have similar episodes 2 weeks before, but I thought that it due to tiredness.
Hmm. And what about the left eye?
No, not affected, only right eye.
And you lost the whole of the picture or only part of the picture?
Actually, doctor, it start to lose a part of vision part, but later on, all parts affected.
Do you feel like a curtain falling in front of your eyes?
Yes, doctor, yes, like this.
And is it pain? Was it painful?
No, I didn't feel any pain.
And how much time you remained this loss of vision?
Actually, it's different. First time it was only 10 minutes, but second time was about 20 minutes.
And how when you regained slowly or suddenly?
Yeah, doctor, yes, actually it's returned over about 5 minutes.
And was any loss of vision after you finished this attack? How was your vision after this?
Yeah, I feel okay now.
Any pain in your eyes?
No,
Any redness?
no, doctor, no redness.
And any problem with color vision?
No.
Do you feel
Only I feel
blurriness?
black only in front of me, doctor, that time.
Okay. And do you feel any blurring of vision?
No,
Do you have any headaches, Mr. Khalid?
no, doctor.
And any weakness in any body part?
No,
Any trauma to your head recently?
no.
Right. I understand that you have high blood pressures. Is it so?
Yes, doctor, I have hypertension.
Since how long?
Actually, doctor, since 10 years.
Are you taking any medicine for that?
Yes, doctor, I'm taking amlodipine.
Right. And are you compliant with the medicine?
Yes, I taking it regularly.
Are you going? Do you know and are you going for your regular follow-ups to your eye doctor and kidney doctor?
Yes, doctor, I have regular follow-up with kidney with my GP, but he did the frequently kidney functions, and he told me that it's okay.
Did you ever check your cholesterol levels and sugar levels also?
Yes, frequently, doctor, regularly with my GP. He told me everything is okay.
Any disease that runs in the family?
Yeah, doctor, actually, my father has a stroke when he was 60 years.
How is he doing now?
He is died, doctor,
I'm sorry
since
to
long
know
time.
this.
Yeah,
I'm sorry to know this, Mr. Khalid. Are you using any other medicine apart from amlodipine?
only amlodipine, doctor.
And do you smoke?
Yeah, doctor, really, I'm smoking.
How much cigarettes per day? And how
Only
long?
10, only 10 cigarette, doctor. Since long time,
And what about alcohol?
I'm not drinking.
What do you do for living, Mr. Khalid?
Doctor, I was working as teacher.
Hmm. And how this all affecting you? I mean, with these frequent attacks must be quite difficult.
Really, doctor, I now I didn't go. I have no any job now. But was before I was as a teacher. Now retired.
And do you drive?
Yes, doctor, I'm driving my car.
Hmm. So, Mr. Khalid, now I will examine you. Is it fine?
Yeah, please, doctor.
Any pain anywhere else? Any pain anywhere?
No.
So, I will be gentle. If you feel any discomfort, let me know.
Yeah, please.
So, I will have a look at the eyes to see any tosses or anything like this,
Okay.
apparently. Then I
Okay.
will check the visual acuity by finger counting. Please close your right eye and then see my finger and then the other eye.
Nice. Normal.
Okay. Then I will do this visual fields one by one in the
Yeah.
both eyes.
Okay. It's normal also.
I will make an etch in front of your eyes. If you feel any double blood or pain, please let me know. I will make an etch to see any nystagmus, anything like that.
Okay.
And I can then check pupillary reflexes, this direct and indirect both.
Normal.
I will offer fundoscopy.
No need.
No need.
The examiner told you no need, but you should offer it. Okay.
Yeah, and I will just try to see the maybe tone or power in maybe lower limbs, or I can offer walk to see there is any,
What you will do in examination?
I will check tone, maybe tone in the legs or arms
Okay,
to
it's normal.
to see
No,
any weakness, residual weakness,
tone is are normal,
or
and power
reflexes.
reflexes symmetric and normal.
Okay, okay. Uh, then then okay. So, Mr. Smith, Mr. Khalid, do you have any concern for me?
Is it stroke, doctor?
Well, Mr. Khalid, after listening to you and after examining you, uh, is it not a stroke, but it is something we call as a mini stroke, and we should take as a warning shot.
So, doctor, will it happen again later?
Well, Mr. Khalid, I'm really afraid to tell you that if we ignore it and if we not do any proper care for it, there are chances it may happen again.
So, what I
And
should do, doctor, to avoid it in
uh,
future?
we should. I will suggest that you should stop smoking, and
Yeah,
meanwhile, stopping driving will be a better idea till we fix this issue.
yeah.
And we will refer you to the mini stroke clinic. They will do scan of your brain, and
When you will do this brain scan for me, doctor?
within 24 hours, Mr. Khalid.
Ah, so okay,
Yes.
it's okay, doctor.
And meanwhile,
Yeah.
I will suggest you not to drive till we fix this issue. And we
So,
may
doctor,
start you.
yeah, you told me that you will do scan within 24 hours. So you will admit me in hospital, or I can go home?
Well, Mr. Khalid, we don't need to admit you in the hospital, but
Yes.
it will be wiser if you stay with us till we get an appointment. Then you can come and do the scan.
Okay, 1 minute, doctor. Okay.
So, yes. So, Mr. Khalid, do you have any other concern for me?
No, doctor, thank you.
Okay. Um, okay, thank you, Mr. Khalid. Thank you
Thank
very
you.
much.
Thank you. Thank you. So, Dr. Tanzil, I know that now examination will not take time in this situation.
Yes, you're right. You're right.
You are right, you are right. But really, also in examination, in exam situation, also in this case, you will not examine many parts of the body. But very important in this case, very, very important and critical if you don't examine the pulse and
Yes.
carotid arteries. Carotid
Yes.
artery
Yes.
really in this case, you will lose at least 4 marks. You will lose examination because the examiner know that eye examination will be normal in this situation. So what the benefit to examine the eyes here? The most important examination in this case, the pulse, the carotid arteries, heart examination. This is more important than to examine the eyes. Really,
Right. Right.
believe me.
Right. Yes. Yes. Sir, you're right. You're right.
You see, examination of the eyes in this case is not important. Now you should do it, but it's not important. The important thing to examine the carotid and the heart and the pulse.
Yes.
Okay,
You're right.
so
You're right.
for examination, here first start with the hands. Examine the pulse. Look for any atrial fibrillation or weak pulse, and then go to the examine the eyes. Okay, examine the eyes, examine visual acuity, color vision, pupils, and here tell the examiner, because no time, tell the examiner that I will complete my examination by doing visual field, fundus, eye movements. Okay, but important thing to examine visual acuity and to compare both eyes, not only to ask the patient do you see or not do you see. We discussed this before, that sometimes the patient, wait a minute, yeah, we discussed it before that sometimes if the patient has optic neuritis, the patient can see in both eyes, but really there's only blurred vision. So the patient, he will tell you, I can see. But when you ask him if there's any difference between these eyes, he will tell you, yes, I feel blurred vision in one eye. So it's very important not only to examine the visual acuity, also if the patient can see, ask him to compare with the other eyes if there's any
Okay.
difference. Okay? So
Okay,
very
okay.
important. And then go to the examine the carotid artery. Very important to examine carotid artery, both carotid artery, and see if there's any fluid. And you should have at least for heart examination, you should also put your stethoscope on the heart. But for neurological examination here, you can tell the examiner, I will complete my examination by doing full neurological examination. He will tell you no need or no time to do this in this and nowadays in this format of basis exam. But in a new format, you have time also to do neurological examination. So a neurological examination, it's not necessary to do here in this situation, only offer. Tell the examiner, I will do it, because no time to do it. So what's your
Right.
diagnosis, Dr. Tanzil?
My most likely diagnosis, this patient is having amelogenesis fugax,
Yes?
secondary to maybe hypertension.
Okay. This patient has multiple risk factors for transient ischemic attack, hypertension, age, and also smoking.
Yeah, smoking also risk factor, yes.
Okay. طيب. Uh, what we will do for this patient as investigation?
Investigations, I will like to do this ECG
Okay.
and lipid levels,
Yeah.
and I would like to do this MRI within 24 hours.
Okay.
And echo can be helpful. ECG and echo both can be helpful
Echo what for what?
for any heart abnormalities.
For what? What? Which part? You will do echo for which part of the body?
Echocardiography.
Echocardiography. Yes. Yes. Okay. Other echo. You will do other echo or ultrasound.
Really, I'm not sure.
See, doctor, this rule: transient ischemic attack, carotid
Oh
droplet
yes,
part. This is the
yes,
rule.
yes, yes.
Not only in the exam, in our life.
Yes, yes, you're right.
Patient with TIA, especially TIA, not stroke. Stroke, yes, not necessary sometimes if the patient has complete hemiplegia, because the surgery will not be urgent. But TIA sometimes in arthrectomy will be urgent. Now I will ask the question. So my question here for patient with TIA, according to NICE guidelines, you will do CT brain for them.
Yes, according to the new nice guideline, we should do CT or MRI within 24 hours.
Which one? You will do CT or MRI?
Don't,
So,
I think yes.
NICE guidelines 2019, they told clearly that if you have suspected TIA and the patient symptoms improved, so don't offer CT brain scanning unless there is clinical suspicion of other diagnosis. I will ask you later. So, should the patient assist within 24 hours and do MRI with diffusion time? MRI with diffusion time. Okay? So, no
So
need to
every
do CT.
for every patient of TIA, we will do
TIA.
MRI.
TIA now, no need do CT scan. If I will tell you what the indication to do CT scan. But as general, any patient you suspect that he has TIA symptoms, it means that the patient's symptoms improved within 1 hour, within 2 hours. So this patient no need to do CT scan, offer MRI directly.
Okay, okay,
For carotid ultrasound should be done also within 24 hours. Okay? طيب.
okay, sir. Okay.
I will
Noted
I
and
will
memorized.
I will mention other points later on. Treatment. What treatment you will offer for this patient?
Sir, we can optimize the antihypertensive treatment,
Yeah.
and we can add antihypertensive, and we can also start him on aspirin and
Aspirin,
statin.
how much you will start aspirin?
There is a dose 300 milligram
Yes.
for some time, then we will reduce to
How long? For how long will
2 weeks.
continue?
2 weeks.
2 weeks. Okay. And for statin, you will start now or not
We
necessary to
will
start
start
now?
statin. We will start statin now, at the
You will
same
start
time,
statin now. Why?
because it has a protective effect in the stroke TIA patient. Protect.
Okay. Now also according to NICE guidelines. Here only we follow NICE guidelines. Maybe there's the American guidelines will be different, but in examination we'll follow either NICE guidelines or Royal College guidelines. Not follow American guidelines. American guidelines will tell you other thing, okay? But here, according to NICE guidelines, this is also 2019, aspirin 300 milligram unless contraindicated, okay?
Right.
Okay. This is aspirin should be last for 2 weeks. We'll start then long-term treatment. Long-term treatment mean that maybe clopidogrel or aspirin. This is according to the other comorbidities. I mean, if the patient has previous TIA or ischemic stroke with while taking aspirin, so you can offer for him clopidogrel. American guidelines, no. American guidelines tell you if the patient has TIA or minor stroke, you should give him dual therapy, aspirin and clopidogrel. But NICE guidelines tell you aspirin 300 milligram for 2 weeks to start long-term therapy. And
Right.
the patient should be seen within 24 hours of onset of symptoms by specialist, okay? And for scoring ABCD2, if the examiner tell you is does this score still using in assessment patients with TIA, so what's your answer?
No, it is nowadays not used, but we
Yeah,
have to send every patient within 24 hours.
you are
We have
right.
to refer.
So nowadays, according to NICE guidelines, don't use a scoring system. Okay? But you see, this is score, American guidelines still use it. Okay? So we are discussing, we are confirmed that this is NICE guidelines and should apply. In the examination, this guideline should be applied. So don't use a scoring system, very important. Okay. As we mentioned, aspirin for 2 weeks after onset of stroke symptoms, and we can start later long-term antithrombotic treatment. So for statins, also the guidelines tell immediate initiation of statin treatment is not recommended in people with acute stroke. But if the patient already taking statin, so continue it. So this is very important. This is nothing new. This is nothing new. This is from 2008. This is guidelines, not different from previous guidelines. Okay, for statin, no need to start immediately unless the patient already taking statin. This is the most important question now I will ask you. What
Okay.
are the indication of carotid endarterectomy?
Sir, if there is stenosis more than 75%,
75.
yes,
I can accept other opinion from other colleague.
this is my perception.
Yes, 55%.
Come, how much?
55 according to European
50.
system.
70 to 99%. 70% to 99%.
طبعا.
If it's symptomatic
Now.
and more than 70, then should be.
Yeah.
He's
Okay, thank you.
Symptomatic
All-
75 to 99.
Okay. So now also I will discuss, this is guidelines, NICE guidelines, maybe also the different guidelines would be different, like American also. So for people with stable neurological symptoms from acute non-disabling stroke or TIA who have symptomatic carotid stenosis, 50 to 99% according to North American symptomatic carotid endarterectomy trial. So this patient should referred urgently for carotid arterectomy. So 50 to 99, okay? But patient less than, this is for symptomatic patient, very important, not asymptomatic patient, I mean here for symptomatic patient, okay? For symptomatic patient, now, this is guidelines, 50 to 99, 50 to 99, okay?
Right.
And also, the patient receive medical treatment as controlled blood pressure, antiplatelet agents, cholesterol lowering through diet and drug and lifestyle device. But patient, people with stable neurological symptoms from acute stroke or TIA, but carotid less than 50, so according to this is criteria, North American criteria, okay? Or less than 70, you see here, one doctor answered me that 70, but please in examination, you should tell the examiner 50 to 90% according to North American symptomatic carotid arterectomy, because we have two criteria for carotid artery, and the most applied criteria worldwide is this North American symptomatic carotid arterectomy. So please follow this criteria, better for you. Yes, according to the other criteria, like European carotid surgery, should be 70%, you are right. But for North American symptomatic carotid arterectomy should be 50 to 99%. So let us approve that in examination, if the examiner asks you this question, answer him that if the symptomatic patient have stenosis from 50 to 99 according to North American symptomatic carotid arterectomy trials.
Right.
So, doctor, this last question I will ask you. Indication for non-enhanced CT in patient with suspected ischemic stroke according to NICE guidelines.
If we are suspecting any, really, I'm not sure, doctor. Can you please explain?
Yeah, as we agree that if the patient comes to ER with weakness or loss of vision lasts for certain time and improves completely, this patient should offer MRI rather than CT. But there some indication for CT if suspect stroke, if there's indication for thrombolysis or thrombectomy, like patient come to you with limb weakness and still have weakness and you decide to start thrombectomy or thrombolysis. So this is first indication. If the patient is taking anticoagulant treatment, okay? If the patient has decreased level of consciousness, GCS below 13. If the patient has unexplained progressive or fluctuating symptoms. If the patient has papilledema, neck stiffness, or fever. If the patient has severe headache at the onset of stroke symptoms. So this is indication if the patient indicated to thrombolysis or thrombectomy, if the patient on anticoagulant therapy, if he has decreased level of consciousness, if he has unexplained progressive or fluctuating symptoms, if has papilledema, neck stiffness or fever, or severe headache at the onset of stroke symptoms. Why I explain more?
Or if he has fits.
Yeah, you are right. Why I explain today more about this issue? Because really this case, simple case. And nobody should take less than 28 in examination in this case, really. Because it's very simple, really it's very simple. From outside, 58-year-old man has decreased vision or loss of vision. So what's your differential diagnosis from outside?
Yes, I was thinking that this might be amyloidosis fugax.
Yeah.
I was thinking maybe retinal artery, this occlusion, central retinal artery occlusion.
You see, in examination, basis-wise, yes, you are right. You should think other this, but in basis-wise, only in old patient like this, put two or three differential diagnoses in your mind. If it's acute, so put amyloidosis fugax and giant cell arthritis, temporal arthritis. If it's chronic, so you should put in your mind diabetic retinopathy or other. So here, from outside, you should, and if you face it case 58-year-old man like this case has loss of vision, you should know that you should take 28 from 28, really. You should have no doubt. Why? Because it's very simple. Diagnosis in your pocket. And now I explain you what you should do. First of all, in examination, the first of all, carotid and the pulse and the heart. This is the most important parts of examination. Yes, you should examine the eyes, you should examine the visual acuity, but the most important, carotid, pulse, heart. According to the treatment, in this case, why sometimes nowadays bring it in the examination, only to know that you know the new guidelines. Only this, for this. Yani you should know that now the patient, if it has TIA symptoms, you should do MRI first. You should know that you should start aspirin 300 milligram. You should know that no need to do ABCD2 scoring. This is the most important, and the indication of endarterectomy. Only this. If you know everything, خلاص, you will take full marks. So, from outside, if the patient has transient loss of vision, painless, and unilateral, so amyloidosis fogax, this is the first differential diagnosis. Transient loss of consciousness, okay? If the patient has painful, you should put in your mind giant cell arthritis in old patient. Why? Because also giant cell arthritis can be transient, not necessarily always to be progressive or chronic. Sometimes can be transient before the patient to develop complete loss of consciousness. So in giant cell arthritis, and this came many times in examination, transient loss of vision, but painful. The patient will have jaw claudication, will have scalp tenderness, okay? And for young patient, if the patient is young, you should put in your mind optic neuritis. But usually the optic neuritis, the symptoms should be last more than 24 hours, will not be for short time, for 5 minutes or 10 minutes, okay? So if the patient has loss of vision, old patient have loss of vision for a few minutes, so put in your mind, if painless amyloidosis fogax is painful giant cell arthritis. For young patient, don't forget migraine and optic neuritis. Any patient with loss of vision, you should ask these questions. If he has a previous attack, onset, it comes suddenly or gradually. Course, it increase or decrease or same. And the duration. Ask if it affects one eye or both eyes. Ask if does it increase when the patient cough or strain or bending forward to rule out intracranial hypertension. Timing, very important. This is for retinitis pigmentosa. Time is very important for retinitis pigmentosa because, as we know, that the symptoms will be more at the dusk time or in the dark room. So, ask the patient if you feel that the symptoms increase at dusk time. Okay? Field, ask patient which part of vision affected, if the central part or the sides parts. If he tell you the sides parts, ask him, do you bumping into the object when walk? Then ask him about associations, headache, eye pain. Not only headache, ask about eye pain. Maybe sometimes in the patient with optic neuritis, the patient will not has headache, usually has eye pain. Patient with optic neuritis, usually the patient have eye pain. So you should ask about headache, eye pain, double vision, color vision, redness of the eyes and gritty eyes, flashes of the light. Here the patient see flashes around the light. This is also usually seen in patient with retinitis pigmentosa. So not only headache and eye pain. Maybe the patient tell you, no doctor, I have no headache. But when you ask him, you have eye pain? Yes, I have pain in my eyes, especially when I move my eyes. This is characteristic for optic neuritis. Please, any question?
Is there an indication for admission in TIA?
Yeah. If you guarantee that the patient will be seen within 24 hours with a specialist and everything will be done, no need. So, any hospital in worldwide can the patient seen by the specialist and do MRI within 24 hours. I think not available here in worldwide. So this patient need admission. In my opinion, need admission because in the guidelines it's clear mention that if the patient can be seen from a specialist, it should be seen from a specialist within 24 hours. So tell the examiner, yes, I will admit the patient because this patient should be assessed by a specialist and by MRI within 24 hours.
Doctor, what is the indication of clopidogrel in TIA? Is there any indication of clopidogrel or no?
For clopidogrel.
Clopidogrel.
Yeah, you are right. Really, until now, in acute management of TIA, I mean, if the patient presented now with symptoms of TIA, until now, American guidelines and NICE guidelines tell you high dose of aspirin, 300 milligram, and there is no rule of clopidogrel in acute management. But after 2 weeks of treatment with acute management, yes, there's rule to start clopidogrel. Okay, so acute management, now the patient present to ER with acute symptoms of TIA, only aspirin. Your answer, aspirin. If the examiner tell you, is there indication for clopidogrel? Tell him now, no. But later on, we can add the patient when the patient investigate and confirm the diagnosis of TIA, we can add it.
Dr. Hassan, my question is also related with this. It is a second TIA as per history. So we read in some materials that the patient has a multiple TIA, we should start the direct clopidogrel rather than this.
No. You see, doctor, it's clearly mentioned in the American guidelines that mention that until now, there is no study confirmed the benefits of clopidogrel in acute management of stroke or TIA. So if you have patient now already on aspirin 81 milligram and develop new stroke, so you should start with the aspirin 300 milligram while to confirm diagnosis and do full investigation. And when you will discharge the patient, you can start as prophylactic treatment, prevention therapy, clopidogrel. But now when the symptoms start now, that choose aspirin 300 milligram. But yes, when you discharge patient from hospital for long-term therapy, preventive therapy, you can give him clopidogrel. Yes, you are right.
Yes, doctor, this 300 is a loading dose and then 500 milligram daily or 300?
Daily, yes. No, 300 daily for 2 weeks.
Yeah.
It's mentioned for 2 weeks or up to discharge patient from hospital with long-term therapy. I think.
Actually, doctor, both aspirin and clopidogrel will be continued after discharge of the patient.
Yeah, actually, my colleague, according to American guidelines, if the patient has TIA or minor stroke, after you discharge patient from hospital, you will give him aspirin and the clopidogrel for 3 weeks, 3 weeks to 3 months, okay? And then you can switch him to one of them. So, aspirin and the clopidogrel only 3 weeks to 3 months. After, you should switch him to one of them only.
Okay, thank you.
Dr. Hassan just missed it. 3 weeks to 3 months, and after that, what did you say?
Switch one of them.
Oh, yeah. Okay.
Yeah, if the patient has already on aspirin and develops stroke while taking aspirin, so no benefit to give him aspirin now. Give him clopidogrel.
Oh, okay. After 3 months, no? After 3 months.
After 3 months, yes, 3 months, according to American guidelines. But for NICE guidelines, really, only they mention like this: give aspirin 300 milligram up to 2 weeks, and after that, this will decide by doctor. Long-term management, this decide by doctors. But this means, if you read later on in the studies, that if the patient already on aspirin, so we'll give him clopidogrel because maybe the patient will not take any benefit from aspirin.
Okay.
Dr. Hassan, should we start aspirin immediately before doing the imaging or before rolling out any other bleeding? For example?
As we know, this is old rule that antiplatelet should start within 24 to 48 hours. As we know, any patient come with TIA or stroke, if no indication for thrombolysis therapy, antiplatelet should be started as soon as possible within 24 to 48 hours. Okay. So this patient have transient symptoms. I'm sorry, there's this patient has transient symptoms, focal neurological symptoms. So this patient, you suspect that he has TIA. Yes, start aspirin also before to do imaging. Yes, before, because this is your diagnosis, this TIA. In this case, your diagnosis TIA, but you should do investigation to confirm, to rule out other diagnosis and evaluate the carotid.
Okay, Dr. Hassan, but when to give the combination of aspirin and dipyridamole in such case?
Nowadays, in the all new guidelines, there is no any rule for dipyridamole. Only aspirin and clopidogrel.
Any
Nobody
rules
mentioned.
for non-steroidal anticoagulant?
Please, I will tell you about it. But please, Doctor, previous question, you asked me what you complete your question?
Dr. Hassan, my question actually is that the patient is first time either came with the TIA or the stroke. So same will apply, start the aspirin 300 for both?
Yeah. If for a stroke patient, if there is no indication for thrombolysis therapy, yes, start 300 milligram. طيب, if the patient has EF and TIA, EF and TIA, not stroke, when you will start anticoagulant? Anybody know the answer?
Yes, after 2 weeks.
No.
After 2 weeks.
No. This is TIA. I ask you TIA, not stroke.
I think it will be our target will be rhythm or rate control for such a patient.
If there is atrial fibrillation or any problems in heartbeats.
Yeah. Doctor, if the patient has a stroke, yes, you should delay treatment with anticoagulant up to 2 weeks if the patient has a stroke, because we have concern about bleeding transformation. But if the patient has TIA, only TIA, you should start within also 24 to 48 hours. Here, no need to give aspirin, only anticoagulant. TIA, this means there is no risk of bleeding, because in stroke we're afraid that this stroke will transfer to bleeding. But here, no risk for bleeding. TIA, the patient has no lesion in the brain. If you did now MRI, you will not see any lesion. So indication for anticoagulant will be also as soon as possible, within 24 to 48 hours. But if the patient has a stroke, yes, you delay the treatment up to 2 weeks.
Dr. Hassan,
yes, please.
Can you please repeat the imaging in TIA when we should do?
Yeah, if you suspect that patient have TIA, and I mean the patient come to you and tell you I have limb weakness last only 1 hour or less or like this, so this patient no need to do CT brain, only refer him to MRI, okay, and carotid artery. But sometimes we need to do CT scan if the patient indicated for thrombolysis therapy, and I mean patient come to you with weakness and still has weakness, you should do CT. If the patient already on anticoagulation treatment, if the patient has decreased level of consciousness, unexplained progressive or fluctuating symptoms, or the patient has papilledema, fever, neck stiffness, or he has severe headache at the onset of a stroke symptoms. Now, this is what's mentioned in the guidelines. But for other causes like seizure, also one indication to do CT if the patient presented with seizure. But really, this is not mentioned in guidelines, but you can also tell the examiner this one. No problem.
Thank you, Dr. Hassan.
Okay. We can
So, Dr. Hassan, in case of TIA, so we immediately start. We will not wait for the anticoagulant. We will not like stroke. Stroke we will wait, but TIA we will start immediately.
Yeah. TIA, if the patient has transient symptoms and improve completely, you can start.
Okay, thank you.
And really, this is what we should apply also in our life. If the patient come to you with symptoms clear that this is TIA, and the patient his symptoms improved, so it's better to start as soon as possible within 24 hours to 48 hours. So if you feel that the patient, you will admit the patient. If you feel now you cannot do MRI now, you need to do MRI after 24 hours because you admit the patient at night. We suppose that you admit the patient at night and MRI will be done tomorrow morning. So we have 12 hours. So better to start for him aspirin. In our hospital here, we request CT for all patients. This is other issue. But according to the guidelines, NICE guidelines, MRI the best choice.
Dr. Hassan, in stroke or TIA, is there is an indication to combine anticoagulant and aspirin?
Yes, there is, as we tell you, that if the patient has TIA or minor stroke, there's indication for dual therapy, but not immediately, not after stroke immediately. When you discharge patient as a preventive therapy, we know that in stroke we have acute therapy and preventive therapy. Acute therapy will be now, this 24 hours to 48 hours, okay? So no indication combination. But when you discharge patient from hospital, yes, there's indication for combination if the patient has TIA or minor stroke.
Anticoagulation and aspirin. Anticoagulation and aspirin.
Anticoagulation, as we mentioned, if the patient has TIA, no, a combination of anticoagulation.
Combination, my question.
Actually, this only in this some indication for combination. I will tell you when. If the patient has atrial fibrillation and he developed stroke while taking anticoagulation with INR within therapeutic range, and you find that he has also carotid stenosis. Yes, in this case, we can give combination. If the patient develops stroke while taking warfarin and INR within the therapeutic range, so and he has atherosclerosis in carotid artery, yes, you can give combination. Other than the risk from combination, more than the benefit, really will increase the possibility of bleeding. So only one indication, this is for combination.
Any rules for novel anticoagulants?
Yeah, yes, if the patient has atrial fibrillation and no valvular disease, yes, the best choice to give novel anticoagulant.
Sorry, doctor, accumulate combination of what?
Now, they asked me about warfarin and anticoagulant and aspirin. She asked me, doctor.
Aspirin and
doctor, after stroke, how much much you will stop warfarin, for example, in case of valvular prosthesis, and you will restart warfarin after how much time?
Doctor, if the patient has this is complicated case. If the patient has prosthetic valve, you mean, huh?
Yes, prosthetic valve
Actually,
on warfarin, and later on presented with the stroke.
Yeah, this
when you will restart.
Until now, there is no fixed guidelines about this. No fixed guidelines, but really, this is according to the experts. This depends on the size of ischemic stroke, size of the stroke, if it's mild or large, and also the risk of thrombosis by this. But really, as I'm working as a neurologist, really in this case, I start after 48 hours. Why? Because the risk of thrombosis or the risk of defect in the prosthetic valve more than the bleeding. So for me, I start after 48 hours, but with caution, really. And I observe patient closely. But there's other expert opinion, that up to 1 week. But really, believe me, that better to start as soon as possible for patient with prosthetic valve. Really, if a patient also have a bleeding, if the patient has intracerebral hemorrhage, really I try to start as soon as possible. Sometimes within 1 week I will start. Because really the risk of thrombosis very high in the patient has prosthetic valve.
Yeah, there will be any need for heparin to bridge, or just stopping warfarin and giving nothing?
You mean when you resume? Yes, better.
Before you resume warfarin, you
you are right. Yes, better. To give heparin, yes, better.
Thank you.
Excuse me, sir. Is there any chance that TIA resemble a minor bleed? there are chances that in clinical
Well,
practice
you are right, doctor. You are right. Really, I have many patients. I have many patients come with me with transient symptoms, and when did CT, we find that they have minor bleeding. But how many patients like this scenario? Very low. And you know that in Western countries, they do large studies. And when you find that this is very minor patient that, have like this, so they will neglect this one. I mean, they will do guidelines. As I will give you other example. If you have patients have headache and fulfill all criteria of migraine, you will do MRI for him according to guidelines? No. But how many patients you see in your life fulfill the criteria of migraine, and when you do CT, they have a tumor? There is. So according to the guidelines, this is to guide you how it's working.
97.
But sometimes your opinion is more important. So according to guidelines, yes, no need to do any investigation up to do MRI.
And I'm afraid, doctor, that if we are giving after 12 hours this aspirin to such type of patient,
No problem. No problem.
Yes, okay.
As I mentioned, 24 to 48 hours, not necessary to give now immediately in this moment.
Okay, okay, thank you.
Next, please. Dr. Sami, you are here?
Doctor, sorry. Addition to TIA, you give aspirin after 12 to 24 hours?
No, it's recommended that patient presenting with TIA to start antiplatelet within 24 to 48 hours. This is the opinions. I mean, don't late treatment up to 72 hours or 4 days or 5 days.
Why not start after excluding the hemorrhage by CT?
Start. This means that you can start after 1 hour. You can start now, this moment. This means that it's better to start within 24 to 48 hours and don't late more. But you can start after 1 hour, 2 hours, 3 hours, no problem.
Yes, I understood. Thanks.
Dr. Sami is here? Dr. Sami? Dr. Mu'tamad? Dr. Sami?
Yes, I am here. Yes, I am here.
Dr. Mu'tamad?
Yes, I am.
So please concentrate with me with this case because it's a good case and maybe difficult. So you have 2 minutes only to prepare yourself.